Hey everyone. So, if you're a medical trainee, you have almost certainly faced this exact dilemma. What to do with non-selective beta blockers in a patient with cirrhosis. It seems pretty straightforward on the surface, but the why behind it all, that's where things get really fascinating. Let's just dive right in with a classic clinical question. Okay, so put yourself in this situation. It's a classic case, something you're going to see all the time. Your patient's endoscopy shows they have these high-risk varices. Now, the guidelines say you've got a choice. You can do endoscopic banding, or you can start a beta blocker. So, what's the right call? And that's exactly what we're going to unpack here. Look, banding isn't a wrong answer, but there is a really compelling argument that starting a non-selective beta blocker, an NSBB, is actually the better move, because as we're about to see, these pills do so much more than just treat what you see on a camera. To really get why, we have to start with the basics. The mechanism. How in the world do these drugs actually work to, calm the storm that is portal hypertension? The real magic is in that phrase, non-selective. The beta-1 blockade happens in the heart, and yeah, that reduces cardiac output, which definitely helps, but the key effect, the real star of the show, is the beta-2 blockade. That happens in the splanchnic vessels, the blood vessels in the gut. This makes them constrict, which reduces the amount of blood flowing into the portal system in the first place. That directly tackles the pressure problem. That's the main event right there. Our whole understanding of these drugs has been a journey. It started way back in 1980 with the Lebruck trial, which was the first to show, hey, propranolol can actually lower portal pressure. Then, fast forward to 2005, the Grossman trial asked a bigger question. Can we use these even earlier to stop varices from ever showing up? And the surprising result of that trial is what eventually led to this massive paradigm shift in 2019 with the Presley trial, which basically changed the entire goal of what we're trying to do. Okay, so let's dig into that evidence. Because that 2005 trial I mentioned, well, at first, it just caused a ton of confusion. But its negative result actually led to one of the single most important insights we have for managing cirrhosis today. So here's the big puzzle from that Grossman trial. The researchers took patients who had cirrhosis but didn't have any varices yet. They gave them a beta blocker, and nothing. It didn't work. It didn't stop varices from forming. And for years, this was a real head-scratcher. I mean, why would a drug we know lowers portal pressure fail to prevent something that's caused by portal pressure? And the answer lies in this one crucial concept: clinically significant portal hypertension, or CSPH. This isn't just a number, it's a physiological tipping point. Once that pressure gradient hits 10 millimeters of mercury, the body's entire circulatory system flips a switch and goes into this hyperdynamic state. And that was the light bulb moment. The Grossman trial wasn't a failure at all. It was just a masterclass in patient selection. The problem was, it included a bunch of patients who hadn't hit that CSPH tipping point yet. So what we learned is that beta blockers work best once that hyperdynamic circulation has already kicked in, because that's the exact process they're built to counteract. This new insight completely paved the way for a revolutionary trial called Presley. And it was all based on this powerful idea. What if we've been aiming at the wrong target all along? Sure, preventing a bleed is great, but what if we could prevent the liver disease from getting fundamentally worse? Preventing it from decompensating, that is the real prize. And the result was absolutely stunning. Presley took the right patients, people with proven CSCPH, and gave them either a beta blocker or a placebo. The hazard ratio was 0.51. In plain English, that means beta blockers cut the risk of decompensation, which was mostly developing ascites, or death by nearly half. This was a game-changing finding that really shifted the whole goal of therapy. Okay, the evidence is pretty darn compelling, but how do we actually use these drugs on the wards in the clinic? Let's get into the practical side of things, the how-to. We've got a few options, but let's compare the two big ones, propranolol and carvedilol. Now, as you can see from this data, carvedilol is just flat out more potent. It gives you a much bigger drop in that portal pressure gradient compared to good old propranolol. But, and this is a really important but, that extra power comes with a trade-off. Carvedilol also causes a way more significant drop in the patient's blood pressure. And you have to remember that, because hypotension can be a huge problem and a major limiting factor for these patients. Okay, this table here, this is your cheat sheet. Put it in your back pocket. Notice the titration goals are different. For propranolol and nadolol, you're shooting for a heart rate between 55 and 60, as long as your systolic blood pressure stays above 90. But for carvedilol, forget the heart rate. The only goal is to keep that systolic pressure above 90. And check out that last column. This is critical. Carvedilol is generally a no-go if the patient already has ascites.
Of course, no treatment is perfect, right? Nothing comes for free. NSBBs can cause those systemic side effects like feeling tired, dizzy, and that drop in blood pressure. Banding, on the other hand, it has its own set of local problems: chest pain, trouble swallowing for a bit, and even a small risk of bleeding from the bands themselves. This is all part of the shared decision-making you need to have with your patient.
So this brings us to probably the biggest controversy in this whole field. Is it actually safe to use these drugs if your patient is already decompensated, if they already have ascites? And it's a totally valid concern, you know? Are we going to drop their blood pressure so low that we hurt their already stressed out kidneys? Well, it turns out the answer is all about blood pressure. A really key studies show that even in patients with ascites, beta blockers do provide a survival benefit, but only if you can keep their mean arterial pressure, their MAP, at 65 or higher. If it drops below that number, the risks start to outweigh the benefits. So this gives us a really clear therapeutic window and a vital sign we have to watch like a hawk.
Okay, we've gone through the science, the evidence, and the nitty-gritty practical stuff. Let's bring it all together and go right back to that patient we started with, the one with those high-risk varices.
So you've basically got three ways to play this. There's the traditional approach: you see varices, you band varices. Simple. Then there's the super progressive view, which is probably where we're headed in the future, where you just use non-invasive tests to diagnose CSPH and start the beta blocker without even doing a scope. But right now, today, based on all the evidence, the sweet spot is right in the middle. Do the EGD to confirm you're dealing with high-risk varices, but then choose the beta blocker as your primary therapy.
And this is the fundamental reason why. This is the whole take-home point. Banding is a local fix. It's a plumbing job on a specific problem in the esophagus. A non-selective beta blocker, on the other hand, it treats the underlying disease. It targets the entire portal system and has been shown to actually change the natural history of cirrhosis itself. So let's just nail down these key takeaways one more time. First, use these drugs in the right patient, someone with clinically significant portal hypertension. Second, remember the right goal. You're not just trying to stop a bleed, you're trying to stop decompensation. Third, use the right guide. Let blood pressure dictate your choice of drug and your dosing. And finally, remember the right safety rail. If your patient has ascites, keep that MAP above 65. And that really just leaves us with one final question to think about the next time you face this choice on the wards. Are you going to choose the pill that actually alters the course of the disease, or the procedure that just treats the symptom? And hey, before we wrap up, here's a quick clinical pearl for you. We mentioned those red whale marks on high-risk varices. Well, the name actually comes from the textile industry. A whale is the official term for the ridges you see in corduroy fabric. Kind of cool, right? It's a great visual for a really critical sign that tells you the bleeding risk is high.